So mainly back and then radiating down. Okay, alright. So it's going to be on the left side. Okay, alright. So now, first of all, can you please stand up? So on general inspection, patient is alert and comfortable. I do not see any assistive device or any walking frame around the patient. Sometimes they may use walking frame to walk around. Okay. So then after general inspection, we're going to do closer inspection. Okay. Closer inspection, we're going to check the back. Okay. Sorry. I will just place there. Alright. The rest can make notes. So on closer inspection, there is no obvious swelling. So basically for closer inspection, for all the joints or for all the region of the body, you are going through SWAD. Swelling, scar, sinus, skin changes for the S. W is wasting. A is attitude and alignment. And D is deformity. Alright. There's no obvious swelling, no scar, no skin changes, and there's no sinus as well. Okay. The attitude and alignment, how do we comment on the lumbar spine for spine examination? The head is centered over the pelvis. It's not curved to one side. So the alignment is normal. Okay, there's no loss of coronal balance. And then there is no loss of sagittal balance as well. Loss of sagittal balance means that sometimes patient can have kyphosis like that or hyperlordosis. So when you want to comment on the sagittal balance, the pinna of the ear should be in the same line as your shoulder, as your knee, as your ankle. Understand? That is a sagittal balance. Pinna of the ear, and then after that your shoulder, your knee, and your ankle, all in the same line. There is no loss of sagittal balance. Okay? Coronal balance, head centered over the pelvis. Okay? After you comment all these ready, then after that we're going to go to palpation. Look, feel, move, right? So feel for tenderness, temperature, and effusion. But in spine we don't do effusion. So just tenderness and temperature. So how do we check? So you feel there is no increase in warmth at the back. Okay, you don't say that there's no increase in temperature. What is the temperature? So temperature is like everybody has got the temperature. Alright, so it is the warmth and whether it increases compared to the contralateral side. Alright, so there's no increase in warmth. So and then after that, now I'm going to press gently on your back. If you feel any pain, please let me know. Okay, so then after that, sometimes you palpate. For example, if you are a big size guy, it's a very small girl that you are examining. Once you push, the patient can go forward already. Alright? So just try to stabilize it. Okay? So you palpate all the way from the top to the bottom. Okay? And then it's not just that the patient is reporting pain, but rather you need to watch out for the grimace that the patient makes, because tenderness is being evaluated by the grimace. Okay? So you palpate the midline, then you palpate the paraspinal muscle. Understand? So there is no obvious midline bony tenderness, and there's no paraspinal tenderness as well. So then I'm going to ask the patient to move. Okay, now can you please turn here and face there? Alright. So I'll need you to follow my instructions. Okay. So first of all, forward flexion of the lumbar spine. Okay. Go all the way as much as possible. Okay. So when you ask the patient to do this, their knee has got to be extended. Their knee extended like that, and then ask them to flex as much as possible. That's forward flexion of spine. And then extension, go towards the back. Okay, alright. Then lateral flexion. Lateral flexion. Ask the patient to slide their hand down their knee, to touch their knee. Okay, that's like lateral flexion. And then after that, we're going to do rotation. Okay, rotation. Ask them to place their hands here and then rotate towards the right, rotate towards the left. Okay, alright. Now the other test to check for lumbar excursion, lumbar spine excursion, how much they can flex. Any idea? Yes, Schober Test. So how do we do Schober Test?
Mark the PSIS.
Mark the PSIS and then?
At the middle of it, above 10 cm, mark another mark.
Okay, and then after that?
Put the measuring tape down.
Okay.
And ask the patient to bend forward. It should be more than 15 cm.
Yes, so that should be another 5 cm increment. Understand what he says? Okay, those who don't understand, go back and read up about Schober Test. You can do, even if you don't do, I don't think it means a lot. Okay, I mean like it just show that how flexible your spine is and all that. But a lot of times it doesn't really matter to me. Okay, and after that you're gonna ask the patient to walk. Alright, for all spine examination, cervical, lumbar, and then for all lower limb examination, you need to ask the patient to walk. Only hand, you don't have to ask the patient to walk. Shoulder, you don't have to ask the patient to walk. Otherwise, walking is always part of your examination. Okay, alright, for spine. So lumbar spine, because what kind of gait are you going to expect? Naming two.
Trendelenburg.
Trendelenburg Gait. Why Trendelenburg Gait? In the spine, in the lumbar spine.
Hip adductor.
Correct. Weakness of the hip abductor. Why? What nerve supply hip abductor? What nerve supply hip abductor? Superior gluteal nerve. Supplies your gluteus medius and minimus. Alright, now it has got an L5 component. So if you've got an L5 compressive neuropathy, you're going to have a Trendelenburg Gait. Sometimes they can have antalgic gait, it's painful and all that. Then they can have listing. Okay, listing also is possible in this kind of, especially they got a disc prolapse, then they can have listing. Okay, listing means that your body shifts to one side. Okay, now you need to be able to differentiate what's the difference between listing and scoliosis. Okay, so what's the difference?
With scoliosis, like our body alignment is straight, aligned, but listing, the body alignment is
No, scoliosis also can curve like that. Okay, I give you the answer. So listing is just a uniplanar shift of the axis away from the midline. Uniplanar means that listing is just like either this or that. Okay, scoliosis is a 3D spinal deformity. There is rotation as well. There's this rotation as well. Okay, not only that it curves to one side, it's also like that. It's a 3D, 3D thingy. Whereas the listing is just left or right only. Left or right. Okay, this one also got rotation, front, back, and it's a 3D spinal deformity. Okay, that's the difference between listing and scoliosis. Alright, now can you please walk 10 steps forward? Okay, and then come back. Okay. So how you want to comment is that the patient demonstrated a normal gait, alright, and there's no obvious listing to one side or another. Okay, usually for lumbar spine you just comment like that, and you do not notice any Trendelenburg Gait as well. Okay, alright. So how would the Trendelenburg Gait be like if the patient has got a, for example, in this patient, left L5 radiculopathy? How would the body lurch? And where would the pelvis sag to?
The left L5 pelvis should sag to the right.
Correct. Pelvis sag to the contralateral side, body lurch to the ipsilateral side. Okay, let me explain. Okay, let's say now he has got a hip abductor weakness at the left side here. Hip abductor means that it will, this one is your hip, and then this one is your trunk. So basically it closes down the angle, hip abduction. Alright, so when you lift it up like this, it should be able to do its job like that, to bring the pelvis level. Alright, now when this is weak, you'll be like that. Understand? And in order to balance your body will try to lurch to this side in order to balance it. Okay, alright, so here is called Trendelenburg Gait. Pelvis sag to the contralateral side, and then your body lurch to the ipsilateral side. Okay, that's Trendelenburg. So after you ask the patient to walk, and then after that you need to ask the patient to lie down. Okay, alright, so just lie down. So look, feel, move, walk, and then after that you check the neurology. Okay, alright. So always examine the patient from the right side. Always examine from the right side. And if you want to examine from the left side, you need to ask for permission. Now, I would like to ask for permission to examine the patient from the left side. Okay, alright. Now, can you please raise your leg up as high as possible? Okay, tahana, don't let me push it down. And here, don't let me push it down. Now, what nerve am I testing? This one. Hip flexion.
L2.
L2, okay, that's L2. Alright, now straighten your leg, don't let me push it down. Okay, very good. Straighten, don't let me push it down. What nerve is that?
L3.
L3, okay. Now both ankles go up, don't let it come down, okay? Don't let me push it down. What nerve?
L4.
L4, okay. Now both big toes go up, don't let me push it down. Which nerve?
L5.
L5, alright. So in a patient, very classic, if they got a prolapse this or what, and then it is compressing on causing an L5 radiculopathy, you see that all the muscle powers are generally quite okay, except their EHL will be weak. When you do like that, one side will be like that. Okay? But on top of that, sometimes because they can have back pain also, so your hip flexion may get a power of 4 or 4 plus only. Because you ask them to raise, then after that they feel the back pain. But it is not because the pathology is there, but rather because of the back pain, they are unable to give you the full power. So sometimes you don't say, oh, L2 is also, and then L5 is also affected. Sometimes this L2, from a lot of patients, from my experience and all that, is because of back pain. 4, 4, and after that it's all 5, 5, 5 until the big toe. Only then you get a 3 or 2 or 4. It's up to the severity of the pathology. And then after that, now both feet tekan brake, tekan brake, tekan brake. Okay, don't let me push it up. What nerve am I testing?
S1.
S1. Okay, alright. So, of course, you need to check for the tone as well. Okay, so this is what I'm checking for clonus. Okay, more than how many beats will be considered positive? 3 beats. Okay, that's for clonus. So, tone, power, we're going to check for reflex. Anybody got the tendon hammer? So, last time, what we used to check is that we will ask the patient, we'll do like this. Lift it up, and after that, tap, right? Nowadays, the latest one is that a lot of times we just ask the patient to just relax like that. If you see me doing it in the clinic, alright, I just relax the patient's leg or here, ask the patient to relax and then tap. Of course, by right, it should be exposed up to here because you want to observe for the quadriceps contraction. Alright, so this is a very good one, you see. Just relax. Have you feel it? Normal. This is a normal knee reflex. Oh, so hyper. This is hyper already. So that is hyper. That's hyper. Oh, very hyper. Yours. You do MRI already. Okay, alright. So ankle. Ankle. So when I tap here, what are you looking for? Just mention. What are you looking for? Like this one, when I tap here, you are looking for quadriceps contraction. Okay? And it move here. Alright? And after that, you watch for the movement as well of the knee, whether it extend or not. Here. Plantar flexion of your ankle. Okay? And the gastrocnemius, your calf here will contract. Here contract, and after that, here will go down. Understand? See? This is normal. Can you see? It is normal ankle reflex. Okay? Can you see? And the ankle move? It's normal ankle reflex. Okay? But he has got the hyperreflexia of the left knee. Okay? That was hyperreflexia. Alright? So now, Babinski. How do you do Babinski? From medial or from lateral?
Lateral.
Lateral to medial. Remember, from today onwards, lateral to medial. Lateral to medial. Lateral to medial. Babinski are down going. So look for the big toes and all the four toes. See whether it's up or down. Okay, that's Babinski. Alright, so then sensation. Do you have an orange seat or what? Anybody has got before? So you can ask the patient to So you need to give good instructions to the patient, alright? And then after that, to me, you don't have to like, can you feel it? Can you feel it like in the middle of the air like that? And then after that, I think all these are not very good. Like, I don't know, it depends on your lecturer and all that. But to me, it's just like a waste of time, like those middle of the air and all that. Okay, alright. So how does this feel? Is it sharp? Sharp. Okay. So I think you can copy the instructions of what I give to the patient, then after that you can get a clear, good response from your patient. Alright. So this is sharp. Alright. Only two answers you need to give me. Okay. Sharp or less sharp. Right. Once you feel it, please let me know. I'm going to place this on your legs then. Alright. Now close your eyes. Okay. So by right, of course, you need to expose until here. Alright. So if I touch here and I touch 2 times every time. I touch 2 times. The first time is for the patient to localize. Oh, the doctor is touching here. The second time for them to process what is the how significant is it, whether it's sharp or less sharp. Okay, so 2 times. So what nerve am I checking now? This one.
L2.
L1.
L1.
L1 and then L2, L3, okay, and then L4. Sharp, right? Okay, so you need to let me know lah. Okay, and then after that, dorsum of the foot. Dorsum of the foot is what nerve? L5. Okay, so L1, L2, L3. L4 is the medial here, And then L5 is your here anterior aspect all the way down to the dorsum. And then S1 is the lateral aspect of the foot. And then you can check S2 also, it's just behind here, the calf. Okay, alright. Then, after that, we're going to do a straight leg raising test. So you check all those neurology already. I mean, like, of course, for medical school, probably you are asked to check vibration, proprioception, and all that also. But coming to real clinical examination, like if you want to get the diagnosis and all that, it's not so important, vibration and proprioception. Okay, alright. But you can do, just ask the big toes go up, the big toes go down, and ask the patient to tell you whether it's up or down. And then after that, if you want to check for vibration, what tuning fork do you use? 128. Remember, it's 128. Okay. Is there any use of 256 tuning fork?
No.
No. If you buy that, can throw away. Okay. Now, what about 512?
ENT.
ENT, Rini and Weber test. So only two types of tuning fork. Okay. 128 and 512. Alright. So now, straight leg raising test. Okay. So what you need to tell the patient is that if they feel the pain, shooting sensation from the buttock all the way at the posterior aspect of their legs all the way down, then after that you need to let me know. Okay? Now, if I do this straight leg raising test and they feel back pain only, no shooting pain, is that considered SLR positive? No, it's not. Okay? It has got to be a shooting current sensation down from the back down to the posterior aspect of the leg. Okay, alright. So now, I'm going to slowly bring it up, okay? And then after that, if you feel that shooting sensation, you let me know. So usually I will do up to about 70 degrees. I think this is good enough already. You don't have to go more than that. More than that, a lot of people will feel pain. Why? Why more than 70 degrees? A lot of people will start to feel the tightness or pulling sensation behind that. Why is that so?
Hamstring tightness.
Correct. Because of a hamstring tightness. Alright, if I do on you, you don't have any lumbar pathology, but more than 70 degrees, most likely you will feel some pulling sensation because of hamstring tightness. So, what is the up of the range of motion that if the patient feels the shooting sensation, then it's considered positive? What is that degree? From what degree to what degree?
30 to 70.
Correct, 30 to 70 degree. Okay, alright, 30 to 70 degree. Because before 30 degree, your sciatic nerve, the slackness of your sciatic nerve is slowly being taken up. Do you understand that? Because your sciatic nerve goes from here. It's still very slack at this point of time. It's still like, tortuous and all that. But you are trying to tense it, you are trying to tense it, you are trying to tense it. At about 30 degrees, it's now tense enough. Alright? And if it causes any shooting sensation, then that's called SLR positive. Okay? Now, if I do on the other side, okay? But the pain is here, shooting sensation. What is that test called? It's called a cross SLR test. It's called a cross SLR test positive. Okay? The pathology, the patient from the history, the pain is always on the right side. Okay? When I do the SLR here, also it's positive. But when I do the left side, amazingly, the right side also got a shooting sensation. That's called a cross SLR test positive. And it indicates a large disc prolapse. It indicates a large disc prolapse. Alright? Now, it's simple enough up to this point. This is the very, very basic that you need to know for lumbar spine examination. And the next one I'm going to talk about is if you still can absorb, try to absorb. Alright? So, SLR test is also called a Lasegue test. Lasegue. Lasegue test. Okay? Lasegue test. Alright? Now, sometimes if you could probably learn from your lecturer or what, when you leave it up and then there is a shooting sensation, what else can you do? You put it down, and then after that, no more shooting sensation. Then you dorsiflex the ankle. Then after that, the pain is reproduced. Okay, now what test is that called? Sorry? No, all these are for sciatic nerve. Sciatic nerve tension tests are all these. Alright? So that's called a Bragard sign. Bragard sign. Okay? So just now we talked about the SLR test, which is a Lasegue test. Lasegue. Then after that, you slowly bring it down, no more shooting sensation, you dorsiflex the ankle to create the tension within the sciatic nerve. Alright? That's called Bragard sign positive. If, for example, now you bring it down already, and then after that you flex here, and after that you press at the back, at the protracting fossa, and it reproduces the pain. What is that called? What sign is that? No, Scoliosis was survival. That's called a Bowstring Sign. Okay? So you learn a few tests, alright? Lasegue test equals to SLR test. Alright? And then after that you talk about the Bragard sign. Then after that we talk about Bowstring Sign. Okay? Understand so far? Alright. Now, I'm going to show you the Trendelenburg. Okay? Just now we talk about the hip abductor weakness, right? Okay? So, you stand up here, and I'm going to show you how to do a proper Trendelenburg test. Let's say if the patient has got a L5 pathology, walk with a Trendelenburg gait. Alright? So, do you know how to do a Trendelenburg test? We watch from the front or the back?
Back.
The back. Okay, correct. Alright, so you face there. Alright. So first you need to identify the patient. Posterior, superior, iliac spine first. PSIS. Okay? And then after that, let's say now his pathology is on the right side. The hip abductor weakness is at the right side. You ask the patient to stand at the normal side first. Okay? Stand at the normal side, you watch from the back. Alright? So what are the two things you are watching for? Pelvic tilt and shoulder, correct? Okay, so now, when you ask the patient to do a Trendelenburg test, you don't ask the patient to just like that, because the hip should not flex. The knee should flex only. You should ask the patient to do like this, instead of like this. Understand? Okay? You ask them to just bend their knee with this in neutral position. The hip in neutral position. Okay, now, can you please bend your right knee? Bend your right knee only. Bend your right knee, okay? This one. And then try not to support. And then after that, you watch for the PSIS. This is a normal one. Alright? So the normal one should remain level, and then the shoulder is not lurching to one side. Okay? Now, alright, good enough. Now, you can put down your right leg, and then now please bend your left knee. Okay, so let's say now this is the pathology side. So the pelvis will tilt like this or tilt like this. A or B? This is A, this is B. B. Okay? Because it will set to the contralateral side. Because this one cannot bring it back. Understand? So this will tilt like that. And then your shoulder will go here or go there? Go to the ipsilateral side to try to balance it. Okay. Let's say if the patient do this and they cannot balance themselves. Alright. Now what is the third thing you can look for in the Trendelenburg test? Any idea? Okay. Yes. You want to feel the pressure of the palm. Okay. So then in that case, you need to turn the patient already. So from the back, you look for two things: the pelvis tilt, and then after that, you look for the shoulder. Okay. Then now, so let's say the patient cannot balance. Okay. So you ask the patient like this, and then after that, on my shoulder. And then after that, let's say the pathology is on the right? So now, please bend your left knee. Bend your left knee. So the patient will put pressure which side? In order to balance. Left side. Contralateral side. Contralateral side. Because now, the pelvis will tilt to that side. The shoulder is trying to balance to this side. So, obviously you will put the pressure here to try to push it back. Okay, so Trendelenburg test, three things you're looking for. I think you can sit down already. For lumbar breathing. Okay, so Trendelenburg test. From the back, you look for the pelvic tilt to the contralateral side. Shoulder lurch to the ipsilateral side. That is provided that patient can balance themselves. You watch from the back. Patient cannot balance themselves, you go to the front, you ask them to put their hand on your palm. Alright, then you look at the pressure. Okay, so that is actually a Duchenne modification of the Trendelenburg test. Trendelenburg, first of all, they describe these two things only, the shoulder and the pelvis. But this palm pressure is described by Duchenne. So when you have this pressure being placed on the palm, it's called a Duchenne sign positive in a Trendelenburg test. This is your Duchenne muscular dystrophy. Duchenne. Duchenne. So Trendelenburg Test. Okay, any questions so far?